Hello and welcome to the closing day of Digestive Disease Week 2022. I'm Courtney Jones with DDW TV, supported by Fairing. Monday was another busy day on the exhibit floor and around the convention center. Highlights included the AGA Presidential Plenary and DDW Diversity Session. Let's take a look.
The future is now, and we're talking about artificial intelligence here at Digestive Disease Week. I'm Ed Highland with DDW TV. They're exploring the possibility of using AI to predict the possibility of fat accumulation around your organs.
The study I have presented at DDW 2022, it's been a computational framework based on machine learning that we have developed to predict different clinical conditions, mainly intra-abdominal fat and liver fat.
Now, here's some highlights from today's big events.
DDW, I think, is a very unique experience to be able to interact with people that have a lot of different skills and backgrounds and a lot of different interests, and really be able to work translationally across those different specialties with different experts in their fields.
It's really great to be together again with colleagues and to just be able to connect with other people that are like-minded and do the same kind of job that you do. And it's just really great to hear the newest research and then to see how it's applied in real-life patient examples.
It has all these organizations that collaborate for education. I think it's all together: innovation, education, and networking. And then getting to meet mentors, you can have that mentor-mentee relationship. And so I found two mentors, and I think I'm hoping to collaborate with them in the future.
I've been going to these for over 10 years. I started as a postdoctoral fellow, and now, I have my own lab. It's a great way to connect with all the leaders in our field, the upcoming leaders in our field, and it's a great support system.
Representation matters in all forms. It's important for people to see others who look like them, to know that they too can do that. And within the field of gastroenterology, patients want to see providers who look like them.
And that puts a wrap on Monday, but looking ahead to Tuesday, we've got a story for you that is definitely for the dogs. Until then, I'm Ed Highland, DDW TV.
Today is the final day to experience all the insights, learnings, and networking you've come to expect. Here's what's in store. Start your day networking at one of DDW's Breakfast Connections. Then check out a timely symposium, Elective GI Surgery in the COVID Era. You can catch that in person or on the DDW virtual platform. Plus, time to meet the professor. For an additional fee, you can sign up for a luncheon with DDW professors and investigators. Then get hands-on at the AASLD Hepatology Skills Workshop. Finally, as DDW 2022 comes to a close, each society will showcase their best science. Don't miss the Best of DDW 2022 session in room 6DE or on the virtual platform's live stream.
Welcome back to DDW TV. And I have the pleasure now of being joined by Dr. Fola May. Dr. May, thank you so much for coming by and joining us.
Thank you for having me. It's a pleasure to be here.
Fola is the director of the UCLA May Laboratory, which is a health services and clinical research team engaging in research and quality improvement relating to population. I want to get all that in as groundwork here. Tell us a little bit about the May Laboratory first.
Absolutely. So the May Laboratory is a clinical research lab that's based at UCLA Health. We perform research at UCLA, but also in the VA and in federally qualified health centers. And really, we focus on improving the quality of gastrointestinal clinical care.
We do a lot of work focused on cancer prevention, specifically colorectal cancer prevention, but other cancers as well. And we're working in everywhere from patient populations that are being seen at UCLA to community populations, trying to figure out how we can give them the best value of care, but also make sure that they get their preventive services as recommended.
You were talking about colorectal cancer, which obviously is a focal point for much of what is going on here at DDW. Your session also dealt with that a little bit as well. Give us some thoughts, if you would, on how the rise in non-colonoscopy colorectal cancer testing options is improving or has improved the CRC screening landscape.
Absolutely. I love that we focus so much on colorectal cancer here at DDW. It remains the second most common cause of cancer-related deaths in the United States, and it disproportionately impacts low-income African-American individuals. It's an area that I have a lot of passion about, and there's so many fantastic sessions about it here at DDW. We really are trying to focus on how we can develop interventions that make people more aware about cancer prevention strategies. Then we can empower individuals to take that effort to get a cancer screening test. In many cases, that can save individuals' lives. I like to tell patients that if we can diagnose your colorectal cancer at stage 1, the survival is 90%. But if we wait and we delay screening and the cancer screening doesn't happen and you have a stage 3 disease, the survival drops all the way down to 11%. So it's critical that we have these interventions in the community and in health systems. We make people aware about the life-saving potential of screening and that we get as many people screened as possible.
You've touched on it a little bit, but what are some of the challenges to the follow-up after non-colonoscopy tests?
Yeah, so there are many different ways to screen for colorectal cancer. We're kind of lucky compared to other types of cancers. There's actually 7 recommended strategies for screening. Colonoscopy is the most common one, but as you mentioned, we have seen a rise in non-colonoscopic screening tests. These are screening tests often that you can perform at home, like some of the stool-based tests, and it really has increased access to screening. We've learned in our field over time that when you limit the option to colonoscopy, you have a large proportion of the population that's not going to participate at all. So by varying the screening options, we have more people now participating in the screening. The challenge, though, is that these non-colonoscopic screening tests are 2-step processes, meaning that you need to perform the first test, and if that lights up as positive or abnormal, then you actually do need to go for that diagnostic colonoscopy to see if you have a polyp or a cancer. So a lot of the work that we do in our lab and that people around the country are doing are trying to understand what we can do to motivate people to taking that second step if they have an abnormal stool-based test, like a FIT test or a Cologuard or other non-colonoscopic test.
Well, you led right into the next question, which is what are some of the practices that are things that can be done to implement and promote colonoscopy completion after some of these abnormal tests?
Yeah, it's an area that's far understudied. We have a lot of research and implementation science that looks into ways to get more people screened, as we've talked about, and I think we've had great progress in that area, although still much work to do. But we lack the studies that look at how you get people to follow up when you have an abnormal non-colonoscopic test. What we know is that there are a few things that are very effective. One of them is patient navigation. So when we get individuals, they can be lay health workers or health workers, when we get them to get on the telephone and call patients who have had an abnormal test, tell them the importance of that follow-up colonoscopy, walk them through the barriers that are preventing them from getting that colonoscopy, they're much more likely to get that done. We've also learned that some health system interventions, little tweaks in the EHR, nudges to the provider and the patient through letters, mailings, through even text messages or portals through the health system can be very effective in reminding patients the importance of that follow-up examination. But it's an area that I think a lot of us are very interested in, and I'm hopeful to see more science and more research in the future.
And we certainly all are. Dr. May, thank you so much. Thank you for your work with the May Laboratory as well.
Thank you very much.
And this is DDW TV. Of course, if you would like to discover more content, you can always check out ddw.org. Hi, once again, I'm Ed Highland. This is DDW TV. We're talking about the many aspects of the world of digestive disease during DDW, and I'm joined now by Pratik Sharma, who's been here working with ASGE. You've got many sessions going on, all revolving around the subject of artificial intelligence. Give us some thoughts, if you would, on how artificial intelligence is transforming the GI practice.
Yeah, thanks very much, Ed, and it's a pleasure to be here. And as we were discussing, we've done this before, talked about important subjects, and you're absolutely right. Artificial intelligence appears to be a new and upcoming field in gastroenterology, but it's been around in medicine for a number of years, and a number of subspecialties like radiology, cardiology, oncology are way ahead in terms of their use of artificial intelligence in their practice. As far as gastroenterology is concerned, I mean, there are a number of areas where it is having an impact and will have an impact, starting from artificial intelligence in your endoscopy unit, in which the smart endoscopes now can help you find polyps, for example, during colonoscopy. In the clinic, you have these chatbots, as you're aware of, right? You can type your question, and a smart, intelligent chatbot will answer some of those basic questions. So it frees up some time for the physician in order to do that. There are AI-powered applications. So you can download an app, for example, for bowel preparation, or for if you have a patient with inflammatory bowel disease for their symptoms. So, there are multiple ways that, AI is gradually making it way in the field of gastroenterology and endoscopy.
Hey, hate to get to a baseline on this, but it doesn't cost have a factor in this too, because AI has it not only gotten smarter,
right,
but the cost of obtaining and utilizing AI has also come down as well, making it more available to the various practices.
Yes, absolutely. I mean, an example I give is like your smartphones. Right, over time, when the first smartphone came about, it was very expensive. And over time, they've added features to it, and that's exactly what AI does, is that you get more and more features built into it. There are some costs associated with it, but at the end, the downstream savings that you have. So for example, instead of having a nurse answering all these calls, whether it's related to a patient question from a medication or from their bowel preparation prior to colonoscopy, these could be answered by AI-driven applications now. So yes, there may be some upfront costs, but we are hopeful that it will be downstream savings. But most importantly, we have to do what's right for our patients.
Of course, yeah, of course. How can practices embrace and begin to utilize AI? What recommendations are you giving them?
Well, I mean, there are a whole variety of AI devices which are out there. First and foremost, you should identify what's your need, so from a slew of applications that you have available. And then, of course, the important thing, Ed, you mentioned was the cost, right? So what is it that you can or cannot afford? So you have to look into that. But I think it starts right from supply chain, right? I mean, either what you're stocking in terms of your gowns, or you're stocking your accessories for endoscopy, things like that. There are automated ways in which, if they are running out, they can be replenished, so that you don't have to have a person doing a regular bean counter kind of a thing, right? So that's a very simple application which can be done. The other is now clinic notes. So if you were my patient, we're having this conversation, wouldn't it be neat if AI is listening to this conversation and it's scribing all of it? So you don't need minutes after this meeting, right? So similarly, patient encounter, everything is in there. So when I walk out of the room after seeing you, Ed, the note is ready for me to sign, and it's over.
And that saves money, actually, in the long run.
Exactly, so. It does. And plus, it's good for you, because my attention now is on you as a patient, and not on the computer that I need to be finishing my report.
In the few seconds we've got left, what do you see? Do you see something out there that's like, what's the big next thing?
Yeah, so the big next thing, I think, are several things, not just one thing. All of this will lead to personalized medicine, which is that use big data from the endoscopy health records, from the endoscopy reports, from the electronic records, from patient texts, from my notes, putting it all together, and then using this multimodal data to provide personalized medicine to you.
Fabulous. Pratik Sharma, thank you so much for coming by and sharing your knowledge about artificial intelligence.
Thank you very much. It was my pleasure.
And this is DDW TV. I'm Ed Highland. For more information about what's happening at DDW this week, check out ddw.org.
Our vision is to be the most innovative single-use endoscopy company in the world. We believe there is a better way to do endoscopy. We believe patients and healthcare systems deserve a solution which is sterile, which provides convenience, flexibility, and attractive economics. One that leverages the technologies of the future. Ambu, forever forward.
This is DDW TV here at Digestive Disease Week in San Diego, California. Clinicians all across the country and around the world, about 11,000 in person and virtually. Thank you for joining us here at DDW TV, and thanks to Emily Perito who's coming by. She's an AASLD session speaker. We're talking about careers in pediatric hepatology. So give us some thoughts if you would. What's it like? Walk us through a day.
Yeah. It's almost impossible to walk you through a day because I think one of the things I like most about my job is that it's different every day. When I'm on service in the hospital, we round in the neonatal nursery on 2-week-olds, and then we go to the inpatient floor and the ICU and the outpatient clinic and see everything all the way up to 21-year-olds. When I'm not on service in the hospital, I'm seeing a similar breadth of patients in clinic and then doing clinical research.
So what would you say is the most rewarding part of this day that changes on a regular basis?
I think the most rewarding part is there's a few things. One is just learning every day because we have an opportunity to do so many different things in clinical care and in research, and a lot of training and mentoring to residents and fellows and other folks as well. But certainly the interactions with families and being able to follow those families through sometimes what's really critical illness or liver transplant or liver failure towards where their kids are healthy and back at school and running around doing all the things you would want your kids to be doing. That definitely is a gratifying experience.
As a layperson, I have to ask, it must be very different and occasionally difficult because you're talking to the parents and the family members because the patients often are not able to communicate what even their symptoms are, let alone being able to tell you how they feel, what kind of pain they're in. You can just kind of have to guess at some of those things. But how do you work that as a professional, and how do you explain to someone else in hepatology, hey, pediatrics is this for me, this is how it could be for you?
Yeah, I think it's something you practice over time, engaging with kids of different ages and then really engaging with their parents. And you need to do both sort of either sequentially or in parallel. It's one of the really fun parts about our job that we're dealing with parents who just, love their kids so much and would do anything for them, but we need them to be on the same page about making decisions for those kids in medical care. And we also need to respect the family's priorities and figure out a plan of care that works for those families. And then getting to engage with the kids, which is just as fun, maybe more fun, on their level and trying to figure out how are they feeling, what do they understand about this, what can we do to help them, be healthier and happier in their lives.
Well, what are you telling trainees about, where they are in their careers now and why they need to progress in this direction?
Yeah, I think it's a really exciting place to be because there's just such a breadth of what you can do. And in clinic, we see less sick patients with non-alcoholic fatty liver disease, with autoimmune hepatitis, with diseases that are almost always managed as an outpatient. But in the hospital, we see really intense critically ill kids with things like acute liver failure or who have just gone through liver transplant. So I think that it makes the career really dynamic and exciting. There's also a really nice collaborative community of both clinical care folks and researchers in pediatric hepatology. And so because everything that we deal with is pretty rare diseases, having a real community of folks, many of whom are here and in other places, to work with on this is really rewarding and exciting. I learn a lot from them too.
Well, let's say I'm still in school or I'm just beginning my career. What suggestions would you have to essentially dip their toe into this direction of getting onto the pediatric hepatology side.
Yeah, it's not something you might wander into necessarily. You have to look for it a little bit. But I think for the medical trainees, finding clinical experiences where you're doing that, either on the inpatient or outpatient side, is a good way to do it. There are a number of organizations organized around pediatric liver disease and liver transplant, including ASLD. There's a Society for Pediatric Liver Transplant, and more recently a Starzl Network for Excellence in Pediatric Transplantation. So we have websites, we have conferences, and places where you can really start to learn about what is it that we do, what are the challenges in the field, and where do we think we're going with this.
And internship possibilities as well?
Yes, definitely. To do what I do, you do a pediatrics residency, then a pediatric gastroenterology fellowship, and then usually an additional year of training in pediatric liver disease.
Wonderful. Emily Perito, thank you so much for coming by and sharing with us.
Thanks for having me.
And this is DDW TV. If you'd like to learn more about us, you know where to check. It's right at the bottom of the screen. Thanks for joining us.
If your moderate to severe Crohn's disease or ulcerative colitis symptoms are stopping you in your tracks, choose Stelara from the start and move toward lasting remission. Stelara can provide relief after the first dose. And only Stelara offers injections every 2 months, which you may be able to give yourself at home after just 1 IV dose. So instead of symptoms leaving you stuck with doubt, you can keep going with fewer flare-ups.
Stelara may increase your risk of infections, some serious, and cancer. Before treatment, get tested for TB. Tell your doctor if you've had an infection, flu-like symptoms, sores, new skin growths, have had cancer, or if you need a vaccine. PRES, a rare potentially fatal brain condition, may be possible. Some serious allergic reactions and lung inflammation can occur.
Feel unstoppable. Ask your doctor how lasting remission can start with Stelara. Janssen can help you explore cost support options.
I'm Dr. Miguel Reguero, Professor of Medicine and Chair for the Digestive Disease and Surgery Institute and Chair for Gastroenterology, Hepatology, and Nutrition at Cleveland Clinic.
I'm Dr. Ahmed El-Talbani. I'm Associate Professor of Internal Medicine, the Cleveland Clinic and Cleveland Clinic Lerner College of Medicine.
Our study found that dementia was higher in Crohn's disease and ulcerative colitis patients, and we also studied the effect of biologics in this population. And I'll turn it to Dr. El-Talbani to give some of those details.
To add in that, what we found was there was an increased prevalence of dementia among the IBD population. Furthermore, we found there was an association with lower rates of dementia among IBD patients that were treated with biologics.
And the take-home points for the gastroenterologist are in patients over 65, we should screen them and be aware of dementia. And there may be an inverse correlation of biologics in our patients with IBD and dementia.
DDW 2022 may be coming to a close, but don't forget tomorrow's free virtual career fair. The online event will connect GI professionals with potential employers around the country. All you have to do is register online through DDW's website. It's been a great week here at DDW 2022. Remember, you can see session recaps and bonus video interviews by visiting news.ddw.org. Stay tuned for DDW On Demand, which will be available soon, featuring recordings of all of our scientific sessions. And check out the feed on social media. Use the hashtag DDW 2022. Thanks for joining us for DDW TV. I'm Courtney Jones. We'll see you next year.